Welcome to my eating disorders presentation for Social Work 633. My name is Samara Kress. Our client today is Jill. She is a 28-year-old Caucasian heterosexual Catholic female. She is not married and has no children. She is from an upper middle class home, educated as has her BSN, and stands at 5 feet 6 inches and weighs 84 pounds. Jill has been hospitalized 11 times in the past 3 years for eating disorder related issues. For the past 10 months, she has been force fed through a feeding tube. She has had one recent suicide attempt by overdose. She suffers from osteoporosis and poor bone mass, kidney damage, chronic dehydration, depression, and she is infertile due to the loss of her menstrual cycle. Jill presents for treatment after a suicide attempt by overdose. She's been abusing alcohol, is isolating herself, and has been unable to care for herself. Jill is accompanied by her father, who fears for his daughter's life. Jill's mother is emotionally absent and unwilling to face Jill's mental health issues. Jill uses food restriction, compulsion, and weight loss to maintain a sense of control. Historically, she's used weight loss as a way to get positive and negative attention from her parents. Her parents don't talk about the death of Jill's sister, and Jill, unfortunately, was not afforded the opportunity to have trauma or grief counseling subsequent to her sister's passing. Jill's mother began drinking heavily after her sister's death and was therefore not a support to Jill. Jill currently uses alcohol to numb her feelings of sadness and depression. Jill is the only surviving child of an intact family. When Jill was 10 years old, her 14-year-old sister died in a boating accident. Nobody in the family received grief or trauma therapy after that loss. Jill's mother used alcohol to cope with the death, and Jill began binge eating after her sister's death. She gained 15 pounds. Her mom took her to the pediatrician, and the pediatrician put her on an 800-calorie a day diet, and her mother enrolled her in dance classes. Jill quickly lost all of the weight, and both of her parents were delighted and rewarded her with praise and gifts. By the time she was 12, Jill was firmly established in food restriction, and that is when her anorexia became full-blown. Throughout middle school and high school, Jill's weight fluctuated but has been dangerously low. She was a perfectionist, maintained fantastic grades, and was accepted to the college of her choice. Once Jill moved away to college, she dropped down to 76 pounds and began abusing alcohol. Soon, the university became very afraid for her physical safety, and they asked her to leave. Subsequently, Jill enrolled in nursing school, where she earned a BSN, but she has never been strong enough to hold down a job. The etiology of Jill's alcoholism was her predisposition genetically for alcohol abuse, and also she watched her mother abusing alcohol in the home, and her trauma and grief also put her at a greater risk for alcohol abuse. So from a diagnostic standpoint, Jill is diagnosed with anorexia nervosa, restricting type, and her level is severe. She meets this criteria because of her dangerously low body weight, below 15% body fat. She has lost her menstrual period and suffers from debilitating fear of weight gain. And despite her physical danger, which she is aware of, she does not experience herself as thin. Instead, she insists that she needs to lose additional weight. The differential diagnosis to be considered in cases of anorexia nervosa is cancer, AIDS, and hypothyroidism. Jill's second diagnosis is alcohol use disorder, moderate in a controlled environment. Jill has strong cravings, recurrent use, which interferes with her ability to meet her major roles, continued use in spite of interpersonal problems, use in spite of persistent physical problems, and work and social interactions are given up in order to use alcohol. Jill currently lives with her parents, who have stopped giving her money for alcohol, so she is now in a controlled environment, which hopefully will help her addiction. Depression could be perceived as a differential diagnosis for her use, but we've ruled this out because of the severity and length of her sustained maladaptive behavior with alcohol and eating disorders. So in terms of eating disorders, prevalence, according to the National Association for Anorexia Nervosa and Associated Disorders, 0.9% of women in America suffer from anorexia. The standardized mortality ratio for anorexia is 5.86%, and 1 out of 5 anorexia fatalities are due to suicide. 33 to 50% of anorexic patients suffer from comorbid diagnoses of obsessive compulsive disorder, anxiety, and substance abuse disorder. And as far as substances, alcohol is typically the substance of addiction for ladies with an anorexia nervosa diagnosis. Of all mental health disorders, eating disorders has the highest mortality rate, and on average, every 62 minutes a woman dies from symptoms secondary to her eating disorder. Theories. As Americans, we value the slender female form. Individuals with eating disorders become fixated on calories, weight, and appearance. Eating disorders are precipitated by a wide range of stressors, included but not limited to mass media and propaganda of women, perfect women's slender bodies. They are also precipitated by self-esteem, low self-esteem, body dysmorphia, perfectionism, sexual trauma, loss of a loved one, which in Jill's case is the issue, and weight-related bullying. And I don't know about y'all, but putting a 10-year-old on such a restrictive diet feels like bullying to me. Jane did not receive counseling after the death of her sister and used her control over food as a coping mechanism. Later in her college years, she began to abuse alcohol to mask her sadness, low self-esteem, and also to navigate the transition of her life. Eating disorders, historically, anorexia is prevalent in cultures that value the slender female form. Anorexia nervosa is most common in high-income populations, So you're going to see this intense obsession with weight and fear of weight gain, predominantly in American, Japanese, European countries, Eastern Europe, Western Europe, not Eastern Europe, New Zealand, and Australia. For alcohol, experimentation with drugs and alcohol is common. It's a common rite of passage in the United States. And of course, individuals with a history of trauma are at a greater risk for alcohol and drug abuse. Individuals who are raised around alcohol abuse are more likely to mimic that behavior. Individuals with mental health problems are more likely to abuse alcohol. And although wine is used in religious ceremonies as the blood of Jesus, there are religions and cultures who prohibit the consumption of alcohol. The articles that I chose, one was Alcohol Abuse and Dysfunction, Eating in Adolescent Girls, the Influence of Individual Differences in Sensitivity to Reward and Punishment. And this was a really interesting article because of the fact that food was withheld from Jill when they put her on that extreme diet, and she was in fact rewarded once she lost the 15 pounds. In this study, 232 high school girls took the Drive for Thinness Scale and the Alcohol Use Disorder Identification Test, and the results of the study indicated that girls who showed intensified sensitivity to punishment and reward were more likely to abuse alcohol and have maladaptive eating habits. The second article was entitled Recognizing Alcohol and Drug Abuse in Patients with Eating Disorders. This article explores the comorbidity that exists between eating disorders and substance abuse. And a review of the research suggests that addictive personality is a principal trait which acts as a predictor for both eating disorders and alcohol abuse. Impulsivity is another personality trait which has been found to be a trait shared by young women with comorbid food and alcohol abuse issues. So I appreciate you all listening to my presentation, and I hope that you all enjoyed and learned a little bit about Jill and her struggles with substance abuse and her eating disorders. Thanks so much. Take care.